All right, good morning, everyone.
Good morning. Welcome to Pediatric Grand Rounds.
Today's speaker is Dr. Lakhdir. Dr. Lakhdir trained at the Aga Khan University in Pakistan, completed a residency at University of Florida in pediatrics, worked for many years in Texas, and has been with the Carilion organization for the last 15 years. Currently works at the Jefferson Outpatient Pediatrics Division and likes to crochet.
She's a fellowship.
Please welcome. Sorry.
She's a fellowship in nephrology.
In a past life, yes.
Please welcome Dr. Lakhdir.
Okay, so I have no disclosures. So my objective today would be to differentiate between worrisome and reassuring lymphadenopathy, and that's going to be a focus. And also to develop a differential diagnosis for the most common causes of cervical lymphadenopathy, because it causes a lot of angst anytime a mother comes in and says, oh, I have this knot in the neck. And they panic, and then you panic too. So this is very commonly seen in the setting of a viral illness, and the incidence is very hard to determine. There have not been very many recent studies actually looking at the incidence of cervical lymphadenopathy. Studies in the past have shown variable incidence. In less than 5 years, one study found that there were 44% had palpable lymph nodes at well-child checks and 64% at 6 visits, and that the incidence is most commonly between 3 and 5 years of age. Other studies have said that between 3 weeks and 6 months, you can have 62% of children that have palpable lymph nodes, and between 2 and 5 years, about 41%, and between 4 to 8 years, 90%. I feel like all children that come in have some amount of palpable cervical lymphadenopathy, so I'm not sure why the numbers were so low. And typically, this is benign, and if you take a good history and physical, most times you can make the diagnosis. So let's get some definitions here. So cervical lymphadenopathy will include both inflamed and non-inflamed nodes. Cervical lymphadenitis, strictly speaking, is nodes that are inflamed. And this typically is an infectious etiology, but lymphadenopathy and lymphadenitis are used interchangeably. So acute lymphadenitis, it develops over a few days, but may persist for weeks. Subacute or chronic lymphadenitis develops over weeks to months. Shoddy nodes. Now, us old people, we tend to use this word a lot. And I never knew where this shoddy came from, but apparently it was describing lymph nodes that look like buckshot under the skin. I don't know what a buckshot is, never seen it, but that's what it is.
Buckshot is the size of the pellets inside the shell.
Right. So a lot of times I hear people say shoddy. It's not shoddy, it's shotty lymph nodes. That's just and then us old people also use matted nodes, and that's something that is not, I don't see it in notes because you probably don't see much matted, thankfully. And this just means that the nodes are fused or discolored. So why do lymph nodes enlarge? There may be a number of reasons. You can have increase in the number of lymphocytes that are responding to the presence of an antigen. There's inflow of inflammatory cells that happens in infection. You can have in situ proliferation of malignant cells, or you can have metastatic infiltration from outside. So how big is too big? Anybody? Students? Residents? Attending? So yes, it depends on the age and the location, okay? So it depends on where you're looking. If you're looking at cervical, then more than 1 centimeter is considered abnormal, and in the inguinal area. But if you're looking at axillary, apparently it's 1.5 centimeters. And if you see epitrochlear nodes, so 0.5 centimeters is abnormal. And how about supraclavicular? Anybody? Always abnormal. So if you feel it, it's abnormal, okay? And the size is less, you don't pay as much, you do pay attention to the size, but it's less stringent than in younger children than in older kids. So, just as a reminder, so these are all the lymph nodes in the head and neck. So that's why, we get so concerned when we see all these. So there's the preauricular, the parotid, the tonsillar, also called the jugular digastric. You have the submandibular, the submental, which is under the chin, and then you have the superficial cervical, the deep cervical, posterior cervical. And even though the supraclavicular, strictly speaking, isn't part of this chain, it's still included because of its significance. The supraclavicular actually drains the thorax and the abdomen and not the head and neck. And this is kind of important when you're trying to figure out why the lymph node is large. Having some knowledge of anatomy is great. So what is the clinical approach? What should we do? What should we ask? What should our history and physical contain? So the time of onset is very important. So if it's acute, most likely it's going to be bacterial or viral, usually. You need to get a good exposure history. Is there any contact with animals, any ill contacts, any unpasteurized milk, which becomes important in infection with Mycobacterium bovis and brucella, undercooked meats, which again is a problem with Toxoplasma, medications, and I had forgotten that dilantin can cause lymphadenopathy. And then flea or tick bites, which can be important in tularemia. We'll discuss it. Travel. So travel is very important, especially to areas that are endemic for tuberculosis. And then associated symptoms always, weight loss, night sweats, rash, fever, arthritis, arthralgias. So the location can usually direct you to where, what the problem is. So you always want to look in the area of drainage of that lymph node. So if you have submandibular that are enlarged, then you think about pharyngitis. Preauricular may be enlarged in conjunctivitis. And then localized versus generalized. Again, anytime you feel lymph nodes, even though it is normal and we see them in every patient, it's a good idea to look for other lymph node enlargement and to put a hand on the belly to look for hepatosplenomegaly. And when we say generalized, we mean more than two or more lymph node groups involved. So the cervical is just considered one group. So if you have bilateral, that doesn't mean there's two groups. It's just considered one group. So what do you look for when you're examining the lymph node? You look for tenderness, redness, fluctuance, warmth, and whether they are soft or not, mobile or not. Hard nodes are very concerning, and because cancers can cause fibrosis. So if you feel a node that feels hard to you, you would rather refer for a biopsy sooner rather than later. Firm and rubbery, again, you worry about lymphomatous change. Fixed and matted could be invasive cancers or inflammation such as tuberculosis or sarcoidosis. So always, like we talked about, make sure there's no hepatosplenomegaly and other nodal involvement. Poor dental hygiene, so look in the mouth. If they have poor dental hygiene, they will have enlarged lymph nodes. If they have mouth sores, herpetic gingivostomatitis or Coxsackie or something like that, or viral pharyngitis, bacterial pharyngitis, they will have enlarged lymph nodes. Look for any skin lesions. A lot of times we forget to do that. So look for a local skin lesion in the area of drainage of that lymph node. And then, of course, look for generalized rashes. So what's worrisome? The location. Supraclavicular, always bad. So you want to make sure that anytime you feel lymph nodes in the neck, that you put your hand, and it's easy enough to feel for a supraclavicular lymph node. Always try to determine the consistency. If it's hard, it's bad. And if it's fixed, you can't move it, because most lymph nodes, they're very freely mobile. And of course, if it's matted, then it's abnormal. Of course, we already mentioned the size, okay? So then other things, weight loss, abnormal chest X-ray, abnormal CBC if you had one, and splenomegaly if you don't suspect a viral etiology. So reassuring anywhere but supraclavicular. So if you see it anywhere, you're not that, not that as concerned. If it's smooth, if it's soft, if it's mobile, and if it's a typical pattern for common causes, and we're going to talk about that in a minute, and if you got a chest X-ray for some reason and it's normal, then that reassures you. Okay, so now, case 1. Let's see how much. So a 2-year-old boy is brought to the office with swelling on the right side of the neck. He had a runny nose, fever, cough 7 days earlier, which is now better. The mother noted some swelling on the right side of the neck 3 days earlier, and now says that the child is complaining of discomfort in the area of the swelling. On physical exam, his temperature is 38 degrees centigrade and normal vitals. And he has a 1.1 to 1.5 centimeter palpable node in the right anterior cervical chain, which is somewhat tender but movable, and there is no overlying tenderness, warmth, or erythema. Nasal congestion is seen. The remainder of the physical examination are normal. Which of the following is the most appropriate next step in management of this patient? Students. Where are the students? Where? Students, what do you think?
E.
Anybody else? Residents?
B.
Yeah, so that would be reassurance, okay? It's 1 to 1.5. There's no other factors. There's a URI before this, preceding this, so it's just reassurance. So reactive lymphadenopathy is the most common, and it's reaction to infection in the drainage area, like we talked about, pharyngitis, conjunctivitis, URI. But you can think about other chronic viral infections as also being reactive. And then you could say that the cat scratch disease is also reactive because you get a papule and then you get enlargement of the lymph node. And then you can get ulceroglandular and impetigo or tularemia. Now we're going to go to talk about lymphadenitis, and I'm going to talk about the infectious causes. Okay. So case 2, 6-year-old boy with sudden onset of fever, knots in the neck. He also has a headache and abdominal pain. He has a temperature of 39.2 degrees centigrade, bilateral 2 centimeter anterior cervical nodes, which are mildly tender. The abdomen is normal. Can you see the nose? So you can see. It's not very happy too. Okay. The light. Can you see? Do we need less light? You can see there's very erythematous, anterior fossa pillars, uvular edema. What's the most likely diagnosis? Come on, students. Strep throat, mono, viral URI, or D?
A.
Come on. B, okay. Any other guesses? It actually could be C too, because viral URIs can do it, but the D is the right answer. So it could be infectious mono, or it could be strep. So what I've done is, well, I didn't do it after they did it, but so it's divided into this classification, and I found that this is really a nice way to remember what causes the lymphadenitis with the different presentations. So you can have acute bilateral, so lymph nodes get enlarged over days, right? Acute, and they're bilateral, so it'll be on both sides of the neck. This is the most common clinical presentation. So with URIs, with strep, with mono. So you'll usually, with acute URIs, you'll usually find the shoddy lymph nodes that are not minimally tender and can last for weeks. Group A strep, common cause, they'll come in. For some reason, kids sometimes don't have a sore throat, but they'll have enlarged lymph nodes and fever, and then their strep test will be positive. Primary herpetic gingival stomatitis, but then you'll see it on exam, or you'll see the inflamed gums and vesicles in the mouth. And then EBV and CMV usually cause subacute, but can present with acute bilateral. Bacterium hemolyticum is a gram-positive bacillus that causes pharyngitis, and this is common in adolescents. So in adolescents, if you see a culture negative that looks like strep, make sure you culture those patients. We should be culturing them anyway, but especially in adolescents. So this is a nice slide, but it's kind of busy, but it pretty much talks about the infectious causes. And you can see that virus, up to here. So, and then group A, strep. Mycoplasma can also in older children cause a pharyngitis with enlarged lymph nodes. And then uncommon causes. Again, most of these are also viral. We don't see diphtheria in this part of the world anyway, so those are kind of rare causes. Okay, so let's move on. 1-year-old girl presents with 2 days history of fever, swelling on the right side of her neck. Physical exam reveals a very fussy, febrile child with obvious neck swelling. She has an ill-defined, red, warm, tender swelling of the left anterior cervical region. Clearly you can see that, right? See how red and just angry looking it looks. So, this is for the attendings. Staph is the most common cause of this presentation. It can be caused by group B strep in neonates, can be caused by contact with bite of blood-sucking arthropods. A and B are correct, all are correct.
E.
I'm sorry, what? E, when there's all are correct, it usually is. Okay, yeah, all are correct. And we'll talk about. So acute unilateral. So we went from acute bilateral, viral, to acute unilateral. Now this is less frequent. And it's usually caused by Staph aureus and group A strep, but can be caused by group B strep in young infants under than 3 months of age. So depending on what you read, 40 to 89% are caused by Staph. Could be methicillin sensitive, but there's increasingly MRSA. Clinically, you cannot differentiate between strep and Staph in these cases. 80%, up to 80% can be under 5 years of age, and 50% of the time is the submandibular nodes that are affected. And the node can be up to 3 to 6 centimeters in size, warm, red, poorly mobile, not discrete, and usually have fever but don't have to, and the child doesn't usually look toxic. This can happen suddenly, like overnight. They can wake up and have a huge. This can occur in older children with periodontal disease. So it's very important if you see an older child, look in the mouth and make sure that the dentition that this is not an abscess from periodontal disease, because the treatment would be different because these will be anaerobe, slightly different. So I put tularemia in because it's one of those rare causes, but it's kind of interesting. And this is a disease that can be caused by blood-sucking arthropods, right? It's a febrile illness. Okay, so a contact history is very important. There may be contact with infected animals, rabbits, hamsters, other rodents. They may have had a bee or a tick bite, or this is also called deer fly fever, so they've been around. Common presentation, you'll have a papular lesion and drainage buildup. Can you hear me in the back? Yeah? Okay. So this is kind of what you might see. Then you can see this until lymph node enlargement. Okay? Not common. Kind of nice. And then you might see a lesion that has almost like a necrotic in the center. Okay. So in the neonate, you can get acute unilateral lymphadenitis from a group B strep, and this is a manifestation of late GBS infection. It can occur in babies 3 weeks to 89 days. Babies will be febrile, poor feeding, it'll be very tender, erythematous, ill-defined swelling. And the majority of these babies are bacteremic. If you see an infant under 3 months of age that has lymphadenitis, that patient needs to be in the hospital. So again, this is just a nice little chart go to upstate and get it. And this shows that, you know, these are the most common causes, and then you have the uncommon causes. Now, they always put in Yersinia pestis that causes bubonic plague. I don't know if we'll ever see that, but there. And Pasteurella, though, cat bite and exposure, that would be again, a good contact. So subacute or chronic lymphadenitis is mostly caused by chronic viral infection, EBV and CMV. Can occur in tuberculosis and HIV and in toxo, but EBV and CMV are by far the more common, and it's usually associated with generalized lymphadenopathy. So if you're suspecting EBV, most likely other lymph nodes will be affected. So these are just some, I'm not going to spend too much time on this, but these are the common causes. And then you can see that the rare causes are brucellosis and Mycobacterium TB, Mycobacterium bovis. Okay, moving on. So another case, 2-year-old girl with right-sided facial swelling for 2 weeks, low-grade fever for the first few days. She was placed on Augmentin without improvement. On exam, she has a 2-centimeter, moderately tender purplish node. You can see. Kind of purplish to be. Oh. Is this right there? Typical mycobacteria, or also now called non-tuberculous mycobacteria, cause unilateral lymphadenitis. IND is contraindicated, and atypical lymphadenitis, usually subacute presentation. There may be a history of pica. Only A and B are correct. All are correct. Ending. Oh, very good. So the most common cause of acute unilateral lymphadenitis or lymphadenopathy, because these are not usually very inflamed, are caused by atypical mycobacteria and cat scratch disease. But tuberculosis and toxoplasmosis can also be seen. Most of these non-tuberculous mycobacterial infections are seen under 5 years of age. It's found everywhere in soil, dust, water. There may be a history of pica, as we said, so these younger kids are more likely to be putting in them now. Mycobacterium Avm Complex causes majority of cases. Has anybody, any of the attendings here ever seen this? I've never seen. I've been here 15 years and I haven't seen it. So it's not as common in this part of the world, maybe, but it's something that we need to know. What's that? So typically, it will be on one side non-tender, and it's called a cold node because it's not warm. It doesn't look too inflamed, and it's usually less than 4 centimeters. It enlarges over several weeks, so it's not something that's going to happen acutely. Usually the submandibular, the tonsillar, the jugulo-digastric is also called tonsillar, or the parotid lymph nodes are involved. The skin will have a pink to purple hue, and the skin actually thins over the lymph node, and then once it's thin enough, then you'll get a draining sinus. You may get a draining sinus, and it looks awful when that happens. Okay, next case. 4-year-old brought into clinic by grandmother with a 1-week history of small bump under left eye and small painful node in front of ear. No fever, mildly tender, node with minimal erythema, about 2 centimeters in size. Child appears well. Now, this is a real case. And you can't really see it very well, but kind of the arrows are kind of pointing to it. You can see it's elevated. The auricular. Not very red. Which of the following is true? Often do not recall scratch or bite of cat. Perinose ocular glandular syndrome can occur following conjunctival inoculation. Axillary lymphadenopathy more common than cervical. Sorry, I'm making. Residents? All are correct. I should have put some that were not all correct, but they are all correct. So cat scratch disease, they say that non-tuberculous mycobacteria is more common, but I think cat scratch disease here, I've seen more of cat scratch disease. I don't know what the other attendings, what their experience is, but in the outpatient, we see more cat scratch disease. So it occurs about a week to 2 months after a cat bite or scratch. That the area may be warm, tender, maybe slightly erythematous, but you can get nodes that are not. You may see the papule at the site of inoculation, but sometimes if it's been 2 months, you might not. And axillary is definitely more common, and it makes sense because you're more likely to be scratched on your arms than you are on your face. But 25% of cat scratch disease will occur in the cervical area. Anterior cervical and parotid more commonly affected. And fever can occur in about 30% of patients and can last up to 4 to 6 weeks. Oh, God. There's another node. Sorry, the light there's too much light here. And then this is what, if you get conjunctival, a scratch in your conjunctiva or, whatever, saliva on it, then you can get awful-looking conjunctival inflammation. How about tuberculosis? Not as common in the U.S. And typically it's extension from the peritracheal nodes or to the tonsillar or submandibular nodes. So it's a direct extension. Or it could be direct spread from the apical pleura to the supraclavicular. So those are the postulated hypotheses of how it gets there. But in these cases, you will have symptoms that are compatible with TB, usually weight loss, night sweat, and fever. And then, if you do a chest X-ray, you usually will see some hilar lymphadenopathy. And there may be a history of contacts with tuberculosis or chronic cough, or travel to and from endemic areas. Toxoplasma occurs in about, it can be symptomatic in 10% of patients. You usually get a mononucleosis-like picture. So if you see a patient that you think has EBV, but the titers are negative, and CMV is also negative, then you may want to think about toxoplasma. This is usually benign and self-limited. Posterior nodes will be more likely to be affected, and they can persist for months. And typically, it's ingestion of contaminated meats or accidentally ingesting the oocysts, which, when you're cleaning the litter box, that may happen. Again, non-tuberculous mycobacteria, cat scratch, the common causes. The less common are the ones we just. And this is just a nice. If you had to have one chart, this is a chart to have because it gives you all the common causes and then of the acute bilateral, acute unilateral, chronic unilateral, and chronic bilateral. So now we move to the non-infectious causes, which are way less common, but we have to not forget about these because it would be horrible if we missed that. So connective tissue disorders, there'll be prolonged fever, there'll be rash, arthralgia. So we're talking about lupus and similar connective tissue disorders. The most worrisome, of course, is the neoplasm, okay, because we always worry about that. Is this a tumor? Is this something bad? So typically in this, it'll be persistent, it'll be progressive. You have constitutional symptoms like fever, weight loss, fatigue. Okay, and then these are just, Kawasaki disease won't just present with acute unilateral cervical adenitis. There'll be other things that will point you in the direction of Kawasaki's with fever, rash, conjunctivitis, mucositis, edema of the hand and feet. And then recurrent periodic fever is another cause that can cause cervical lymphadenitis. But then again, you'll have the periodic fever over 4 to 5 days, asthma-stomatitis, pharyngitis, and cervical adenitis. Sarcoidosis is more common, still not very common, but commoner in older kids and adults. You can have significant cervical lymphadenopathy. And then again, there'll be constitutional symptoms. So when you start having a lot of constitutional symptoms, then you start thinking about other things. And African Americans, of course, have a higher incidence of sarcoidosis throughout age. Okay, so let's talk about some new diseases. I've never heard of this, Kimura's disease. Apparently, it's a triad of painless subcutaneous masses in the head and neck with lymphadenopathy, increased serum IgE, and increased eosinophils in the blood and tissue. I love saying this. Kikuchi Fujimoto disease. It was described by Kikuchi and also described by Fujimoto in the same year. So people would give credit to both of them. And it was first described in young women, and it's a rare benign condition of unknown etiology. So they don't know why it happens, but it happens. And typically you'll have fever, you'll have firm, smooth, discrete, mobile lymph nodes. But there may be, constitutional symptoms like weight loss, night sweats, nausea. There may be a transient rash, and when you biopsy these, there's a necrotizing lymphadenitis. It's benign though, but it causes a lot of angst when you see this. Then another rare, Rosai-Dorfman disease. I'm sure the students know all this, right? These are new diseases that I've never heard of. And then you have a sinus histiocytosis with massive lymphadenopathy. And what is sinus histiocytosis? Basically, histiocytes just plug up the channels in the lymph nodes, so it doesn't flow, so it gets bigger. Large, discrete, again, soft, mobile, and you may have raised ESR, increased neutrophils, hypergammaglobulinemia. So this is not completely benign, but rare. So what can look like lymphadenopathy and not be? I think a lot of times we get confused with this, the periodontitis, okay? So experienced clinicians will tell you that you can't mix the two up. You have to be sure that when you examine to rule out periodontitis, that you make, if you see a swelling that's less well-defined, going from in front of the ear to behind the ear, that's not a lymph node. That has to be a parotid gland. And it also hurts when they open their mouth. That's, you have trismus. It does hurt. Branchial cleft cysts, it's possible because they can be lateral. Thyroid tumors, typically in the midline, so less likely. And then Thyroglossal Duct cyst. So how can you diagnose a Thyroglossal Duct cyst? Anybody? Yeah, so make them stick their tongue out, right? If you make them stick their tongue out, it'll move. Okay, because it's attached to the tongue. No, I apologize. I couldn't find a better, but this is kind of ill-defined. Okay, but when you see one, you'll never forget. So, what workup? In most cases, you don't need much of a workup, okay? Unless you have compelling evidence of non-infectious, you focus on initial evaluation on infectious causes. By far the most common. If it's a mild illness, you don't really need any workup. If you suspect strep throat, go ahead and do a strep test, or a culture if you're suspecting Bacterium hemolyticum in adolescents. If it's severe, progressive, persistent, ill-appearing, febrile, lasting longer than 4 to 6 weeks, then you might want to start some workup. So the initial workup typically would just be a CBC, a ESR, or CRP, and viral serology, very important, okay? And then you may or may not do a test for tuberculosis. And then other testing will depend on the history. So we'll go quickly through acute unilateral. Typically, you don't need much workup if there are minimal symptoms. So if you see a kid with a URI, like the first case, small, one lymph node, you may just want elective follow. If you have moderate symptoms, fever, tender, adenitis, and no fluctuants, then you can treat for staph or strep. Now, if you have fluctuants, if it's a very red, angry-looking node that's larger than 2-3 centimeters, you may want to do an ultrasound and do fine needle aspiration. That is an option. So if you think there's a lot of suppuration. And most of the time when you do culture these, 60 to 80% of the time you'll get a positive culture. But sometimes you don't. But that doesn't mean that there isn't on bacterial infection, because anaerobic infections sometimes are difficult to culture because they are fastidious organisms. Now, if there are severe symptoms, ill-appearing, cellulitis, pustules, we all know what to do. Blood culture, CBC, ESR, CRP. You may treat outpatient or you may admit, depends on your clinical judgment and comfort. Ultrasound. So ultrasound, you typically usually will get an ultrasound, but if you feel that there's deeper involvement, then a CT scan may be indicated. And you want to cover for staph and strep and anaerobes if there's periodontal disease. Subacute or chronic, you need to make sure that it's not cat scratch or atypical mycobacteria, so you might get CBC, ESR, peripheral smear. A lot of times we'll get Bartonella titers. And then liver function if you're suspecting EBV. Again, this is optional. If you're suspecting NTM, then you may want to get both of these because it'll be, the TSC will be positive, the tuberculous skin test will be positive, and the quantiferin will be negative, usually, and especially in the MAC complex. And then you can get viral serology, test for tularemia, toxoplasma, and a chest X-ray. If it persists beyond 4 to 8 weeks and there's no clear etiology, then you can repeat the CBC with diff and smear. However, if it's a hard node, you don't wait that long, okay? So you need to, again, it's clinical judgment. If it's a hard node, single, large, not getting any better, then you may want to send for biopsy sooner than later. So excisional biopsy. Now, remember, an atypical mycobacteria, the treatment for atypical mycobacteria in the cervical region, surgical excision has a better outcome. But if it involves the facial nerve, then you have to be careful. And in that case, you would want to treat orally rather than do the excisional biopsy. But you do not want to do an IND in these patients because you will create fistulas and just a very bad cosmetic outcome. So in these cases, if you are sending them for an excisional biopsy, it needs to be to a surgeon who is comfortable and experienced in doing these. And so you would do the excisional biopsy in anyone that you suspected malignancy or suspect tuberculosis or NTM, and if their symptoms are lasting more than 4 to 8 weeks. A lot of sources say wait 8 weeks, but I don't know if we would all be comfortable waiting 2 months for this to get better. So this is kind of their stepwise approach if you don't think it is infectious. So any worrisome features, early biopsy, and then if it's uncertain after initial evaluation and it's less than 2 centimeters, then you can wait. And get some baseline studies and just follow. If it's more than 2 centimeters, you kind of get a little bit more concerned, and then you might want to do these tests. Some authors state that just go ahead and treat with antibiotics. I mean, that's what they say. Even if it doesn't look like it's an acute infection, go ahead and treat with antibiotics. Again, it depends on your clinical judgment. If you're just waiting and you want to do something, I guess you could. But I don't know that I'd do that. I don't know. That's all you do. It just depends on your clinical judgment. So summary, most cervical lymphadenopathy is benign, okay? And the diagnosis, like I said earlier, can be made with a good history and physical. You really need to check the drainage area of lymph nodes. If you have occipital lymph nodes enlarged, I can bet you that there's something on the scalp. It could be tinea, it could be a scratch that got infected, something. So you always need to look to see simple things are more common than these more rare things. Again, infectious causes way more common, but don't disregard any enlarged lymph nodes. Make sure that there's follow-up. Typically, we will see these kids back in 1 to 2 weeks to make sure. Supraclavicular, always worrisome. Okay, ask a few questions. 12-year-old with fatigue for 2 weeks, fever and sore throat for 1 week, temperature 101, non-toxic, has yellow exudate on tonsils, and several 2 by 2 centimeter lymph nodes posterior to the sternocleidomastoid muscles bilaterally, so in the posterior chain, with charty inguinal lymphadenopathy and palpable spleen. What is the most likely diagnosis? Students, you were listening. Mono. Very good. Mono, CMB, but yeah, for this purpose. And not Kikuchi Fujimoto. 14-year-old referred for evaluation of lymph node, which has increased in size over the last 4 weeks. No improvement with 2 weeks of amoxicillin, has low-grade fever. Exam is completely normal except 3 by 2 centimeter hard fixed lymph node in left posterior cervical chain. Which of the following is likely diagnosed to confirm the diagnosis? Students. Anybody? Quickly. Biopsy. Very good. Well, not all that. Yeah, so excisional biopsy. It's a hard node. So if you see a hard fixed node, I mean, that patient needs to get a biopsy yesterday. So, yeah. 1-month-old boy, acute onset of left neck swelling with fever for 1 day. Exam reveals marked swelling in left neck and warm erythematous tender mass that is 5 by 4 centimeters in the anterior triangle. He is febrile and mildly ill-appearing. Which of the following is the most likely cause of his symptoms? Anybody? Good B strep. Okay, so very rare. Just one thing that I was meaning to put in there, but I didn't. Now, even though we say, most lymph nodes, they can be present for weeks and months, and usually is not cancer. Now, there's one exception. Hodgkin's lymphoma can be indolent and can be present for 6 months and can be present in just one node. So that's just something that we just need to be aware of. So we can. Okay, so yeah, could be strep. Okay, thank you for your attention. Questions? Yeah, okay. Go ahead.
Wondering if the new bacteria for the adolescents, which is Corynebacterium, more commonly.
Yeah, it used to be called Corynebacterium. Now it's called Archinobacterium.
Will that grow on the specific beta hemolytic culture, or you have to do the general?
No, you have to do a throat culture. Which after doing this, I realized that I was doing just beta strep cultures for all these because it's more specific, but it doesn't pick up the Archinobacterium hemolytic. So if it's an adolescent that you're sure has strep, then go ahead and send a throat culture.